All righty. So first question that we're going to look at for radiology is for number one. A 40-year-old female is scheduled for a routine screening baseline bilateral mammogram with computer-aided detection or CAD. So what are our ICD-10 and CPT codes? So for this one, your ICD-10, you have 1 and 3, whereas with your CPT, you're able to rule out 2 or confirm 2. So let's go to our 77067 and find our code description for that. So 77067 is our screening mammography bilateral 2-view study of each breast, including your computer aided detection or the CAD when performed. So we do need that one. We're going to rule out A and D, and then we need to decide, do we need Z12.31 or R92.2? So when you have screenings and they're not coming in with any complaints, then I always go to the Z code first because that should be our encounter 4 code. So let's just go to the Z12.31. And that is for encounter for screening mammogram for malignant neoplasm of the breast. Yep. So since they're just coming in for the routine screening, there's not any other complaints or anything like that that is prompting for that mammogram to be done. And it is a true screening mammogram. Then we're going to use our Z12.31. Any questions on that?
Tiffany, I have a question.
Yes, ma'am.
Um, so we just really, the main word in this is screening, not so much as the 2-view study.
Right. Yeah. Yep.
Okay.
Yeah, because if you look at the 77067, that's our screening, right? If you look at the 77066,
That
even though
is
that is
diagnostic.
bilateral, that's for diagnostic.
Yeah.
Yeah. So
Okay.
that screening word is going to be that key indicator. And
Okay.
then just for S's and G's, let's go look at that 77062. And that one is for a diagnostic digital breath tomosynthesis and bilateral. So
Okay.
again, we're just, yep, that screening and mammogram, yep, is our key indicators there. Absolutely. Okay. Any other questions? Okay. Number two, a 56-year-old patient who's been admitted requires a tunneled CV catheter insertion. The physician uses ultrasound guidance in order to perform the insertion, and they have documented vessel patency and that permanent recordings are in the patient's record. So the cardiology code is the same in 3, right? So it's going to be faster to rule out or confirm 2 with that 76937. So let's go there. So 76937 is for ultrasound guidance for vascular access, requiring ultrasound evaluation of your potential access site. So they used ultrasound guidance in order to perform the insertion. So we know we need either A or B. Everybody agree with that? Now, the 26 is appropriate because they are admitted. So that's telling us that this is an inpatient procedure. and therefore they are only doing the professional component of the ultrasound guidance. And then the technical component would be billed for that facility by the facility. So let's go look at 36556 and 558. Because it is possible, okay, and the reason that I brought up the 26 modifier while we're looking up that 36556 and 558, it is possible that on the exam they might have whatever your correct CPT code is for the insertion of the catheter. And then they might have an option of the 76937 with the 26 and then an option without a 26. So make sure that you're paying attention if it's in an admission. Then again, that's your inpatient. Yep. So your 36556 is insertion of a non-tunneled, centrally inserted central venous catheter. And then 36558 is an insertion of a tunneled, centrally inserted central venous catheter without a pump or port. So, yep, we need the 36558, and that's because it is tunneled versus a non-tunnel.
And also that it's oh no, never mind. Never mind, Tiffany. I got it.
No, you're good.
Okay, I was thinking something else. No, but
Nope, you are totally fine. Now, does everybody know the difference between tunneled versus non-tunneled catheters? Does anybody want me to go through the difference of them for you?
Yes, if you could, please.
Okay. So a tunneled catheter is going to go more under the skin, and it's going to be used long term. And then your non-tunneled catheter is going to go directly into a large vein, and that is used for a short term. So tunneled is a long term, non-tunneled is going to be short term. So the way that I remember that is your tunneled is going to go into the skin, and then it's going to go kind of underneath the skin and kind of like snake a little bit. So it's going to have a longer piece of that catheter. So it's a long term. The longer piece of catheter is for a long term. And then your non-tunneled is going to go directly into the vein. So it's going to have a shorter piece for the short term. Okay. Any questions on that or anything else on this question before we move on?
Did you say that short-term non-tunneled goes directly, and then where does the tunneled long-term go?
So the tunnel kind of buries underneath the skin and then it goes directly into the vein. But the reason that it kind of tunnels underneath the skin is so that it holds it in place a little bit longer and a little bit easier. So it still goes into a vein. It just doesn't go directly through the skin into the vein. It tunnels through it and then it goes into the vein.
Okay, thank you.
You're welcome. And if you have, if you get those confused a little bit too, on page 304, it shows you some examples of tunneled versus non-tunneled. So sometimes those illustrations will help kind of make your brain remember that too.
And Tiffany, what were you saying? I'm sorry about the
No, you're fine.
26. How can we remember? I mean, is it you said being admitted versus? I know it
Yep.
means professional component.
Yep.
Is that
So if they're admitted into a facility,
uh-huh?
then the physician that's doing the ultrasound guidance does not own that ultrasound equipment.
Okay.
So therefore, that's why you're 26, because they're only performing the professional component, and then the hospital's going to bill for the technical component.
Okay, gotcha. Thank you.
Yep. You're welcome. So you'll see a lot in radiology, the TC and 26. So just kind of keep that in mind as the kind of the setting that they're in.
Okay.
Okay. All right. Number 3, a parent brings her child into the emergency department and she thinks that she swallowed a small toy figure. A radiology exam from the nose to the rectum is performed and the foreign body is not located. So what CPT code or codes are going to be reported? So for this one, here's a little trick, okay? When you have multiple x-rays that are done, or this is probably more a single x-ray, it's what's known as a babygram. But if you have a radiology exam that's done on multiple areas, always look at the one that is a single code first, because you want to see if we were to report these separately, if we're going to unbundle any. So if we look at the single code first, that's going to help us know, is everything included in the single code or do we need to report it with multiple codes? Does that make sense? So 76010. And that is a radiologic exam from nose to rectum for foreign body single view. So since we did nose to rectum, radiology exam, nose to rectum, then all of that is included in that single code. Does that make sense? So again, make sure that you're looking at the fewest number of codes first to see if everything is included in that single code, or if it's only got certain components and then we need to report other components separately type thing. It'll just kind of help save a little bit of time so that you're not looking at every single one of these before you get down to it. So that's just a little bit of time saver tip. Okay, any questions on that one?
And also because if it's a child too, it says child. So
Yep.
that's another sign. Okay.
Yep. Usually, and that's why I said this one typically will be just a single x-ray because it, like I said, it's known as that babygram.
Mm-hmm.
So it's because they're a child and their anatomic structure is smaller, then they can get it all in a single x-ray. Versus if it wasn't a child, then they would have to take multiple x-rays typically. Yeah.
Makes sense. Okay.
Okay. Okay. Any other questions? Okay. Number 40, or sorry, number 4. I do that every time I see this question. Number 4, a 40-year-old female has cholelithiasis with chronic cholecystitis. She is in the ambulatory surgical center to have a laparoscopic cholecystectomy. A dye was injected to perform an intraoperative cholangiogram, and the surgeon who performed the procedure included a separate report with his interpretation of the cholangiogram that indicated that there was a normal free flow into the duodenum with no evidence of filling defects, with no stones or strictures. So how do you guys want to start this one out? We want to look at the radiology code, even though it's the same code, right? So even though we have the 74300, depending on the code description, we're either going to need a 26 or we're not going to need a 26. So let's go look at the 74300. So our code description is cholangiography and or pancreatography, intraoperative with radiological supervision and interpretation. So do we need the 26 modifier, or are we going to report it with?
You're going to report it without because it's already included.
Okay. If you report it without, yes, the code description states radiological supervision and interpretation, but whenever it says radiological supervision and interpretation, then that means that it's included, and they're also including the technical component as well. Now, if you didn't If the code description said radiological supervision and interpretation only, then you would not have to report your 26. But because in this scenario, they are in an ambulatory surgical center and they only did he's doing a separate report for his interpretation of the cholangiogram, then we should report the 26 months. That makes sense now? So again, your setting is playing a big part in it.
That's how I was thinking, the setting being that she's in the ambulatory surgical center as well.
Yep.
Has a lot to do with it as well.
Yep. Absolutely.
Okay.
Even if they didn't say the ambulatory surgical center, but it specifically states that that separate report with his interpretation was there, then that's telling us that he only did the professional component. But since we do have that detail of the ASC and the fact that he did a separate report, then that's just another indicator that we would need that 26. Okay. Any questions on that part? Does that make sense to everybody now? Again, it's just that wording, and I get it. It feels like they're being sneaky and tricky. But make sure if they give you the detail that it's not in the office or they aren't in a place where they own the equipment. Okay. So now let's go look at our 47563 and 47562. So 47563 is the laparoscopy surgical cholecystectomy with a cholangiography. And then your 47562 is the laparoscopy surgical cholecystectomy. So do you think we need the 62 or the 63? Okay. So I've got a couple in the chat that say the 63. Yep. Because we did both the laparoscopic cholecystectomy and we also did the cholangiogram. So that's going to be our 63. Okay. Any questions on that? Okay. There's a note underneath. Yes, it's on the top of the next column if you have the 2024 CPT. So yes, there is a parenthetical note underneath. It says for intraoperative cholangiography, radiological supervision, and interpretation, the 74300, 74301. Yep. Okay. Any questions? Any thoughts on that one? Number 5, a patient with hydronephrosis has a left nephrostomy and has agreed to a pyelography or an IVP to rule out a right renal obstruction. The patient was placed prone on the X-ray table 1 hour after IV infusion contrast. The contrast flowed from the left and right renal pelvis down to the ureters into the bladder where a Foley catheter was positioned. The IVP showed no obstruction or abnormalities in the urinary tract aside from the left hydronephrosis of the pelvis. The right kidney and ureter showed no obstruction. The bladder appeared with normal limits. So what CPT code are we going to report for the radiological services? So they're all right there pretty close together. So let's go to the 744s. So 74415 is a urography infusion drip technique and or bolus technique with a tomography. 74400 is a urography or a pyelography, intravenous with or without KUB, with or without tomography. 74425 is a urography antegrade radiological supervision and interpretation. And then 74420 is a urography retrograde with or without KUB. So we did the IVP or the pyelography. And they did it with contrast. It showed no abnormalities, all of that. Okay. So yes, it would be the 74400. Because we did not have a drip technique, bolus technique, a nephrotomography, and then it wasn't specified that it was retrograde or antegrade. Okay, any questions on that one? Okay. Number 6, a 25-year-old female in her last trimester of pregnancy comes into her obstetrician's office for a fetal biophysical profile, or a BPP. An ultrasound is used to monitor the fetus's movements, showing 3 movements of the legs and arms, which are normal. There are 2 breathing movements that last 30 seconds, which is normal. The non-stress test of 30 minutes showed that the heartbeat at 120 minutes or 120 beats per minute that increased with movement, which is normal or reactive. Arms and legs were flexed with the fetus's head on its chest, opening and closing of a hand. 2 pockets of amniotic fluid at 3 centimeters were seen in the uterine cavity, which is normal. And then that biophysical profile scored 9 out of 10 points, which is normal or reassuring. So for this one, they're all right there together, but we have 2 that are 76818. So let's go look at our 76818. So 76818 is a fetal biophysical profile with non-stress testing. So that's what we've done, right? That fetal biophysical profile. And then we also did a non-stress test of 30 minutes. So we know we need the 76818, right? So now we need to determine, is that our only code, or do we also need to code 5902? Let's go take a look at that. And then our 59025 is for the fetal non-stress test. So should we report the 59025, or should we only report the 76818? Right. Yep. We're only going to report the 76818. Okay. Any questions on that one? Alrighty. Number 7, a 65-year-old female has a 2.5 centimeter by 2 centimeter non-small cell lung cancer in her right upper lobe. The tumor is inoperable due to severe respiratory conditions, and she is receiving stereotactic body radiation therapy today under image guidance. Beams arranged in 8 fields will deliver 25 grays per fraction for 4. So I would look at our ICD-10. So we see that we have C34.11, right, and 3, and then we have Z51.0 and 3. So what we can do is we need to figure out our sequencing, right? So for our sequencing, should we code the non-small cell lung cancer first, or should we code the Z51.0? So our Z51.0, I'm flipping real quick to get our code description here. Z51.0 is encounter for anti-neoplastic radiation therapy. So should the encounter, or should the first listed diagnosis be the lung cancer, the non-small cell lung cancer, or should it be the encounter for the anti-neoplastic radiation therapy? What is the reason for the encounter? Are they doing anything to evaluate their lung cancer, or are they solely coming in for radiation therapy? I've got some mixed answers in the chat. So this is where your guideline comes into play. So our ICD-10 guidelines indicate that if the reason for the encounter is solely for the administration of, in this case, the radiation therapy, then our radiation therapy encounter code should be our first listing. And then we should list the non-small cell lung cancer. Okay. So that is a guideline that if you're not familiar with it, then that is an important guideline as far as sequencing goes. Okay. So now we don't have to go look at the C3411 if you hadn't already. So let's go look at the 77373 and the 77431. Let's go look at the differences in those. So 77373 is stereotactic body radiation therapy, treatment delivery per fraction to 1 or more lesions, including your imaging guidance, entire course not to exceed 5 fractions. And then your 77431 is radiation therapy management with complete course of therapy consisting of 1 or 2 fractions only. Yep. So 77373 is going to be the actual radiation, the stereotactic radiation therapy. Yep. Okay.
I just realized I had put A first and I meant Z first.
No, you're fine. You are totally fine. So Michelle has a question. Can you distinguish the difference between treatment delivery and treatment management? Yes. Treatment delivery is going to be the actual delivery of the treatment, right? The actual action of giving the radiation therapy. Whereas your treatment management, that is going to be kind of when they are, I guess, managing the dosages, managing like the plan. If you look at your guideline on page 573, you've got bullet points that are there on the left-hand column, and it says that the professional services furnished during the treatment management typically include the review of your images, review of your dosimetry, dose delivery, and treatment parameters, and then the review of the patient treatment setup. So the management is just, we're making sure that our plan is working, right? Versus the delivery is the actual delivery of the treatment itself. Okay. Any other questions? All righty. Number 8, patient is taken to the inpatient cardiac cath lab and 1% lidocaine is infused into the skin of the right groin. The artery is punctured with a needle and then a guide wire with a catheter is advanced into the abdominal aorta. The guide wire is then removed and then contrast medium is injected through the catheter and the abdominal aortography is performed. So we see that the 36200 is the same in all 4. So now we just need to focus on our 770,000 code. So we have 756, 0525, and 30. Let's go look at those. Seven, 5, 6, 0, 5 is for an aortography, thoracic by serialography, radiological supervision and interpretation. 76525 is an aortography, abdominal by serialography, radiological supervision and interpretation. And then your 75630 is for aortography, abdominal plus bilateral iliofemoral lower extremity catheter by serialography, radiological supervision and interpretation. So yes, we did the abdominal aorta. Yep. And then there's really no mention of any lower extremity as well. So we should use the 75625. Yep. And then we need the 26 as well because it is inpatient. So the inpatient cardiac cath. So again, we're only reporting the physician services. Okay, any questions? Number 9, patient has malignant ascites due to ovarian cancer. She is coming back to the operating room for a planned ultrasound-guided abdominal paracentesis. This is the second time that she's needed fluid removed from her abdominal cavity, and the global days for the initial abdominal paracentesis are 0. So we've got 2 that have 49082, and then 2 that have 49083. Let's go look at those. Four 49082 is an abdominal paracentesis, diagnostic or therapeutic without imaging guidance. And then 49083 is with our imaging guidance. So did we use imaging guidance?
No. Oh, no.
We have our ultrasound guided. So that's our imaging guidance. Imaging guidance can be ultrasound, CT, MRI, fluorography, or fluoroscopy, whatever, right? So if they don't state a specific, then imaging guidance can just be anything that helps us determine where that needle is being placed. Okay. So we're going to use our 8.3, right? So if we have 49083, if you look at your parenthetical note directly underneath it, it tells you do not use this code in conjunction with 77002. So we're going to rule out letter A. Now, the other way that you can rule it out, if you didn't see that parenthetical note, is if we are not within a global period, we do not need a 78 modifier for the repeat or the unplanned return to the operating room during the post-op period. So that's another way that you can rule it out if you know that your 78 is that return to the operating room. Okay. Any questions on that one? Okay. Last but not least, number 10. Patient was admitted to observation status after losing control and crashing his motorcycle into the guardrail on the highway. A CT scan of the brain without contrast and the chest is performed. It revealed a fracture of the skull base with no hemorrhage in the brain. There was no puncture of the lungs. And then 3 views of the right and left sides of the rib cage reveal fractures of the left third rib, or the left third and fifth rib. So Vanessa, hang on, I'm going to go back to, let's finish this question and then, I'll go back to the question about, question number 9. So for this one, for number 10, we have a couple different ways that we can rule out. You can look at your ICD-10. Actually, that's probably how I would do it, is look at your ICD-10. Okay. So the S for this first one, okay, your S02.109. S02.109 is fracture of the skull or the base of the skull, unspecified. So we have our skull base, the fracture of the skull base. And then A is for an initial encounter for a closed fracture. And then B is initial encounter for an open fracture. So we are not using B because they did not specify that it was open, right? So guess what? You've got your answer. You don't even have to look at anything else. So without looking at anything else with this one, you've got your answer. Because again, your S02.109, then you just had to determine which 7th character is appropriate. Since they didn't indicate that it was open, then we have to go with the closed fracture. So ones like this, do not let them intimidate you, because you will typically find that you have to look at like 2 codes and you're good. This one we got lucky and there's only one, right? We had the code, but we just had to figure out our 7th character. Okay. Oh, and then on number 9, okay. Number 9, why do we code C first in this case? So are you talking about the C56.9? That one is because the malignant ascites is due to the ovarian cancer. So the ovarian cancer is the reason, is what's bringing them in. So let's look at the C56.9 real quick. So C56.9 is your malignant neoplasm of your unspecified ovary. And then R18.0, you have malignant ascites, but then there's a code note underneath it that says code first your malignancy, such as the malignant neoplasm of the ovary. So that's your second indication that your C56.9 should go first. Okay. Any questions? Anything you guys want to chat about tonight before we're done? Okay. Well, if you all need anything in the next week, don't hesitate to reach out. And then if not, I will chat with everybody next Wednesday. Y'all have a good evening and a good weekend. No, hang on. No, never mind. That's in 2 weeks. Okay, you're good. I'll see everybody next week.
Thank you.
Thank you.